Well, first, I just wanted to thank all the organizers and all of you for being here on your Friday evening. And I think the commitment in this room, and I'm just excited to be a part of mostly younger people than me that are committed to global health. And I think for a lot of us, the last 10 days or so have been challenging. And for me in particular, I think that I was a medical student in New York at 9/11, and right after 9/11, there was this amazing spirit of community that existed. And slowly, as I was, first year med student going into October, it was the first time I started to see people look at me with a certain amount of fear. And it was the first time I felt like potentially I wasn't fully American, but I was born and raised in this country. And I think that global health, in these last few days, I think a lot of us who look like me or others might be asking the question, what is my place in this experiment of America? And I think global health and all of you who are here and are committed to the values of standing up for vulnerable populations, those values of really caring for underserved populations, that is a part of the community that I want to be a part of. And that's the conversation that I'm hoping to push forward here. So with that, I'd like to talk about Global Health 3.0. So I've come from Silicon Valley, and everything in Silicon Valley in the South Bay is 1.0, 2.0, 3.0. And so I'm going to offer up a version of where we've come from in global health, and hopefully where we're going and where I want to go in global health. And so a lot of this comes from my experience in this field. So conflicts of interest, none. I think many of us that work in global health, there is something called the global health tax, where if you're committed to global health, you actually oftentimes have trouble getting supported for the work that you're doing. So definitely don't have any conflict of interest. And the objectives here, so we're going to define global health 1.0, 2.0, 3.0, and then talk about global health delivery. So there's many ways you can do global health, and the specific way that I'm trying to work is on the implementation and delivery side. And then we're going to talk about the HEAL Initiative. And the HEAL Initiative is a program that I co-founded, that is a health workforce capacity building organization. So it aims to build up health workforce in very poor communities, whether that be domestically in Navajo Nation with Native Americans, or in East Oakland, or in 8 countries around the world. So, and I think of HEAL Initiative as not necessarily a solution to the health workforce shortage, but a signpost or a signal as to what we're trying to aspire for in global health. And lastly, try to talk about the global health partnerships and what does global health 3.0 look like, because I don't think many of us are there as what we really want to embody when we talk about solidarity, deep partnerships, all of those things. So Global Health 1.0, I'll start with my own specific example of how I felt like I replicated some of the biases and flaws of how global health is done. And moving to Global Health 2.0, I think HIV movement, thinking of the HIV movement that happened in the late 90s and the 2000s as really an inflection point that got us to where we are today, thinking about global health in a much deeper way. I'll talk about the HEAL Initiative, as I mentioned, and then the Global Health 3.0 is actually a conversation starter and hopefully incubating the idea of where do we want to go from here as a movement of people that care about vulnerable populations. So this was a patient of mine in Burundi. So after I finished residency at Harvard-UCLA at the county population, and just as a disclosure, all of the patients that are shown here are, I've gotten permission to show their picture, or I have there's eyes covered so you can't identify them. But when I was in Burundi, so I finished residency at Harvard-UCLA, and I went to the University of California, San Francisco, and I asked them, could I spend 6 months in San Francisco on the teaching service and then 6 months internationally? And they agreed. And I thought, coming out of a training in Los Angeles, I felt like going to a place like rural Burundi, which is in East Africa, I should be an effective health practitioner. I should be able to plug in and be incredibly useful in that context. But what I found is that this outcome, which is really rewarding and is what we try to do in global health, and which is why a lot of us do global health, is not as common as we need it to be. So this is a young boy, 9 years old, had peritoneal tuberculosis in his belly, was slightly malnourished, and he was diagnosed with tuberculosis and treated. And this is about 6 weeks later. This is a picture of him pretty much cured. And thinking about tuberculosis in this case as a disease of poverty, and he was in very close quarters with his grandfather, got sick, and I was able to treat alongside Burundian health professionals this one patient, but a lot of times I didn't have the skill sets to work in a variety of clinical scenarios that I wasn't comfortable with, whether it's obstetrics or pediatrics or in a lot of cases surgery, but even otherwise, like the non-clinical context. Before I went to Burundi, I never read a single thing about Burundi. I think I probably couldn't identify it on the map before I showed up, and somehow, I thought showing up at this place I would be effective. And so I think it was kind of I probably saw about 12 or 15 kids die of malnutrition in the time I was there in 6 months, and I realized that trajectory of suffering existed long before I arrived and would continue long after I left. And so if I'm going to really commit to a community, how does that look before I get there, after I get there, and what's that plan for long-term relationship building? So coming out of Burundi, understanding some of the colonial roots of global health. And so all of us work in global health in the context that there's a long history that came before us, and a lot of it doesn't have to do with things that we should be very proud of, right? There's a deep colonial history that allows me to pop into Burundi, but very few Burundians can pop over to the United States, right? There's a power dynamic there between our country and theirs. And then, context matters a lot. So all healthcare is ultimately delivered locally, and really understanding the context in which you serve. And so, there was an article I was reading that, this woman who wrote the article said, imagine a 22-year-old Ugandan who was in Uganda and hears about gun violence in the United States and feels like, man, I can solve that problem. I know I can solve that problem of gun violence in the United States. And she or he knows nothing about the Second Amendment, comes over to the States, really has the intention to do good, but doesn't understand the larger context. And a lot of times that's what we're doing in global health. We're stepping into places where we don't bother to learn the history, don't really care about the history, and don't really have the relationships that will allow us to be efficacious. And when you flip it and you talk about the Ugandan coming over here to solve our gun control crisis, or our, that it seems ridiculous, but I think that's partly what we're doing in global health. And then lastly, the will to do good doesn't mean that you have the skills to do that good. So really connecting and thinking about global health as a discipline, which is amazing why conferences like this that push us to really take global health seriously in a deep way. And this is, I think pretty controversial. I think that the Onion, if any of you read the Onion, they posted it's a humor magazine online, and it says the 6-day visit to rural African village completely changes Facebook profile picture. And so it's essentially clowning what global health can be like and what we need to move away from. So I think global health 1.0, there's no doubt this woman has the sweetest of intentions, but I think that at the end of the day, is she doing more good for her Facebook profile picture or the population that she's trying to serve? And then, Teju Cole, when I teach HEAL, we talk about these tweets. So if you guys remember Kony 2012, it was a Ugandan warlord that a lot of people got up in arms. There was a movie that was made about it, and a lot of young people in the U.S. donated. I think a lot of celebrities got involved. And so Teju Cole, who's a Nigerian writer, wrote about 6 tweets, which he termed the white savior industrial complex. And I think, in my role in Burundi, it's not only about race. I think he's also talking about power. And, in my role in Burundi, I think there was a flavor of that white savior industrial complex where you show up and you think that you can really cure a lot of things. And so his first quote, I think I'll just read a couple of them. It says, "The white savior industrial complex is not about justice. It is about having a big emotional experience that validates privilege," right? So we've all heard about global health tourism and trying to move away from that tourism to something that is much more meaningful and deep for the populations that we're trying to serve. And then the last quote that he says is, "Feverish worry over an awful African warlord, but close to 1.5 million Iraqis died from an American war of choice. Worry about that," right? So this idea that oftentimes in global health, you can have a romanticization of other people's problems, right? But at home, in places like in your backyard in Omaha, or where I live in Oakland, there's a lot of issues that are going on. And so if we're going to be engaged in global health, it's not about a geographic location. It's about an orientation to serving poor populations. And, in Haiti, when we worked in Haiti, a lot of the criticism is when a resident who's working in New York City goes to JFK, will fly by, all these different communities that could use their commitment, but they're flying off to Haiti. And so the real solution is not either or, which should I commit to, but it's both. How can we commit to both, right? This patient was a patient of my co-founder for the HEAL initiative in Haiti. So her, I'm not breaking any HIPAA violations because she was also on the cover of the New York Times, and she came in with twitching. Some of you are medical students, and others of you are in different fields, but in medical school we talk about the history of present illness. So she came in twitching. Her jaw was rigid, and like two or three days prior, she had stepped on a rusty object. And so, when you think about, what do you think she has? So exactly. So she has tetanus, and what would you say is the root cause of her tetanus? So lack of immunization. Other thoughts? No shoes. That's good. That's true. Yeah, poverty. So I think that the exercise of going through what is the root cause of this young girl's tetanus can be illustrated, because when I was in county in Los Angeles in residency, I saw a few cases of tetanus, and the exercise of really going back into what is the structural causes of somebody's poor outcome or difficult disease. And so you could start with the bacteria that causes it, and you can get all the way down to political instability and geopolitical oppression, racism. And I think after the Haiti earthquake, I was there in 2010, January 2010. We were there with a bunch of different health professionals, and it was interesting because a lot of times you would have, I came back and I was on a few panels, and oftentimes the person that was on the panel next to me had never been to Haiti and didn't have much experience in that context. But when we were asked questions as to the reason that there's so much suffering in Haiti, the first comment that would arise would be, there's so much corruption in Haiti, right? And so I think that, and that oftentimes frustrated me, because it's a small sliver into a much larger picture, and our job, I think, as global health practitioners is to unpack and really unfold all the causes, that the downstream causes that would cause somebody to have tetanus, and how do we, that if we're working in this field for the long term, how do we start to address those issues? I like this poem. So in my past life in undergrad, I used to write a lot of poetry, perform sometimes on occasion, sometimes bad poetry. But this poem I really like, which is where does the damp come from? So the poet, who's Bertolt Brecht, writes, "When we come to you, our rags are torn off of us, and you listen all over our naked body. As to the cause of our illness, one glance at our rags would tell you more. It is the same cause that wears out our bodies and our clothes. Too much work and too little food make us weak and scrawny. Your prescription says, put on more weight. You might as well tell a fish to go climb a tree. The pain in our shoulder comes from the damp. And this is also the reason for the stain on the wall of our flat. So tell us, where does the damp come from?" So the HIV/AIDS movement, I think that poem, just to go back to that poem, it illustrates the same theme of starting to unpack the root causes, and as global health practitioners, moving from that 1.0 emotional experience of working in a field that's very interesting, takes you to different places and takes you to places all over the world a lot of times. How do we move from that to asking how do we be in partnership and community and commitment in a meaningful way for the long term, and ask the question of where's the root cause of tetanus, and am I working on that root cause, and where does the damp come from? The Lazarus effect. So moving into Global Health 2.0, I think that the HIV movement, which happened in the 1990s and the 2000s, really led to what the second stage, I think, of global health. There's a lot of international health, tropical medicine, then you get to kind of the missionary model of going in a couple weeks out of the year. And I think global health shifted with the HIV movement. And there's a lot written on this, so I won't talk about it too much. But in up until the year 2000 or 2001, 2002, after we had HIV medications in the United States, we were still having the discussion of, should we treat poor people in places like Haiti, in sub-Saharan Africa. And so this question of, if my brother had HIV, of course I would not say, let me wait for the next generation, let me prevent his daughter from having HIV. You would say, get my brother some treatment. And so that conversation a lot of times was couched in cost effectiveness. It wasn't cost effective to treat a patient population in Haiti or sub-Saharan Africa. But, in the US, you had this population of mostly white gay men who were educated and realized they were dying at large numbers, and they were shocked that nobody was really taking notice. And so they got really active, and a lot of their push for really holding, frankly, health professionals accountable led to the HIV/AIDS movement, and led to this was my patient in Burundi as well, along with Dr. Molino, who was with me in Burundi. And this man, Frederic, we found him he was covered in his own stool, very weak, emaciated, and over the course of the community health workers actually found him, and they diagnosed with HIV, treated him for HIV, and over the course of a few months, this is how he looked like. And when he went back to his family, they actually thought he was a ghost because they didn't expect him to survive. And so his wife ran away from him, and they were scared. And so, I think that these outcomes are possible, and the HIV/AIDS movement started to push us to really think, how do we treat the burden of disease that exists in the communities that we're trying to serve? And this hit home for me during the Haiti earthquake. I mentioned I was there in 2010, where there was these amazing orthopedic surgeons, plastic surgeons. I was on the west coast of Haiti in this place called Saint-Marc, where there was a team of 15 Harvard orthopedic surgeons and plastic surgeons. And because I had done some global health work, Partners in Health put me in charge of kind of supporting that health workforce. And I think in the first week or two or three, there was femur fractures and spinal injuries and all of that that you saw. But as time went on, you saw the burden of disease that exists in a destitute, poor population, whether it's a mass or it's, this woman had a space-occupying lesion that, she needed palliative care, and she needed IV morphine and getting access for that. And this young girl had all these wounds that I would change every day, and she was in a motor vehicle accident, right? So one of my mentors in India, he always says that small places don't have small problems. A lot of these rural places have a large burden of disease. And so when we think about how to serve that population, we should think of it similarly to what we would imagine for our own community, wherever we are. And so this, coming out of the Haiti earthquake, there was a paper called Trying to Bridge the Gap Between the Will to Do Good and the Expertise to Do That Good. And so this is the best definition of global health delivery that I've seen, which is treat the burden of disease, and you have an equity agenda to reach the most vulnerable. So you really are trying to be proactive about caring for poor populations. And the goal is to build health workforce capacity locally, right? No matter how committed I am to global health, I have a daughter now, I spend, a couple months a year in rural India, in, other places, but for the most part, it's really going to be the local health workforce that does the real work over the long term. And then getting back to where does the dam come from, addressing the social determinants of health. There's many, many, many ways, as we talked about, with all the disciplines that are involved in global health. So when I talk about global health delivery, even that has a lot of different disciplines, but this is the WHO cycle of all the things that go into global health. And, it's this amalgamation of a whole lot of stuff. And where we're trying to work on is leadership and governance, human resources, service delivery and demand, and with the HEAL initiative. So that's Global Health 2.0, so with the HIV movement. And I think HEAL, what we're trying to do with HEAL, and I'll describe HEAL a little bit, is move from Global Health 2.0 to Global Health 3.0. So, 2.0 was starting to treat the burden of disease. So if somebody, just because it's great to give eye drops for vitamin A, like that's part of your package, or because it's amazing to have a supply chain for vaccinations, but how do you have a deeper imagination of all the burden of disease that exists in the population and start to deliver on that? I think it's, extremely challenging, but I think the HIV movement started us to ask that question. And I think HEAL is, I would like HEAL to get to Global Health 3.0, but I don't think we're there yet. So when we started HEAL, it came from, the experiences in Burundi and Haiti, and my co-founder had worked under Paul Farmer and Jim Kim at Harvard. And after we were in Haiti, we felt that there was so much will amongst so many health professionals to do good, but oftentimes didn't have the expertise, didn't understand the context. So how do we build a program that really does that, and then not make it just about the Americans? Because it can't be a global health fellowship where it's just me flying to different places around the world. How do you build up local health workforce capacity? And so that's some of the questions that seeded what started as HEAL, and as well as the idea that global health is not about a geographic location, it's about an orientation to serve vulnerable populations. So this is the Venn diagram of where HEAL tries to exist. So unmet passion, all of you that are committed to global health, but it's a fellowship on its surface. At its, I think, most base level, it's a fellowship for health professionals that have finished medical school, residency, nursing school, are finished as their minimum amount of training. So you're sending people that have some degree of expertise, and it's a 2-year program over a long term. And then an unmet need at home is in the United States. We work in Oakland. We've started to think about working in Alaska and Rikers Island in the prison system. And we work in Navajo Nation in New Mexico and Arizona. So a lot of our work happens in New Mexico and Arizona. And then we know internationally there's a huge burden of disease. And I think if we have time, I think the funding model for this is interesting, and it's one of these conversations that always comes up because the finances, obviously you have to make things function. And so HEAL, just very shortly, there's in Navajo Nation, I think we'll get to it, is 25% of the physician jobs are completely unfilled. And so they usually pay temp agencies to fill those jobs. And they pay these huge premiums to these temp agencies to get oftentimes, a marginal health workforce to fill those jobs. And so what HEAL does is we come in and we take people that are done with residency, really want to work in poor communities, and they split a job in Navajo Nation. Some of that money flows to HEAL, and then we use that to cross-subsidize the support of Navajo health professionals that have been born and raised in Navajo Nation, are committed to Navajo community, and the same thing internationally. And we have to fundraise as well, but in Liberia we have a community health worker who wants to go to nursing school, and oftentimes in global health there's not much funds to build up that workforce. So HEAL is funding and mentoring her through her transition from a community health worker to a nurse. And so she came into, her name is Alice Johnson, and she came into global health or just the health workforce by seeing a close friend die during childbirth, and she knew, I wanted to be a nurse. And so you have this, with HEAL, you have this cohort of, I'll skip some of these slides, but here's the need abroad. This is our cohort at HEAL, and you have these health professionals that are from Malawi and Navajo Nation and a pediatrician from Michigan, and they're all together in the same room. And I think that's the power of the work, is that they're learning from each other. And so a Nepali's talking about their community health worker program with the Liberian, and there's an ability to really understand frontline health workers that are doing this work day in, day out, learning from each other. And I think that solidarity across nations, across professions, is what we're trying to attempt in HEAL. And so to break down what HEAL looks like, is there's an international site fellows. So we have Nepalis, Indian, Malawians, all of them joining the HEAL Fellowship in 8 countries. And then there's pediatricians from the U.S. that are finished with residency, or internal medicine docs, or surgeons, or emergency medicine docs. And then there's right now Navajo Nation, mostly nurses from Navajo Nation, some physicians, and they're all a cohort together, and they all go through this for 2 years, and they're able to get an advanced degree that is relevant to them, whether it's an MPH or a training from the London School, or in the case of Alice, like a nursing school in Monrovia in Liberia. And so that's I think that pod of 4 is what we're trying to build, that level of community and communion amongst health professionals across countries that are all trying to serve poor populations. And so here's some of our sites all over the world, and we're trying to go deeper now. We have over 70 health professionals right now in different parts of the world. And I think this is why I think that we're not at 3.0, we're still at Global Health 2.0, because as we launch this organization and this fellowship that tries to build health workforce capacity in Navajo Nation or Liberia, when you're trying to build equity in a very unequal world, there's all these challenges that come up. And being relevant to a emergency medicine doctor. So Tamara Augustine is an emergency medicine doctor that trained in Detroit. And this is Alice, who's born and raised in Liberia. And the bar, I think, is so low for what our site fellows, what our Navajo Nation health professionals ask for, or what the Liberians ask for, that they're not demanding that much of HEAL, because they're not used to really pushing for equity, not really expecting that a health program or their career is going to be developed. But an American pediatrician, if they join HEAL, they're definitely going to say, like, I could make 150K somewhere. I'm joining HEAL. I'm spending 2 years of my life committed to this. I expect this level of mentorship, this advanced degree. And so there's a disconnect, and and not to mention we worked in Liberia during Ebola, and a lot of our the American colleagues, when Ebola hit, had the choice of evacuating, right? And that's not something that Liberian HEAL fellows have the option of doing. So it becomes this incredibly complex, nuanced, challenging thing to build something that truly is relevant to the values that we all state that we have, which is building equity, which is moving towards justice, which is supporting health workforce in very poor communities. So the other things is in India, for example, most of the physicians speak English and they can take advantage of HEAL, but some of the rural places, the nurses or the community health workers, they're not very fluent in English. So that becomes an inequitable filter that we didn't intend on, right? So I'll skip some of the other pieces. So I think in summary of Global Health 2.0, we're trying to treat the burden of disease. This idea of reciprocity, I think global health programs have started to talk about that. I think at UCSF we have a lot of Ugandan researchers and different people from other parts of the world coming and spending time in our institutions, and I think that's an important part of the conversation. When I was on my Fulbright, I remember, one of my mentors, he was saying that if an Indian national wants to do a sub-I, fourth-year rotation in an American academic institution, there's a pretty hefty fee that you have to pay. But if they were a site for another medical institution, and so he brought up the fact of, maybe this medical institution should be paying for their fourth-year medical students to do a rotation in rural India. And when he brought that up to the leadership at the medical school, they kind of said, oh, this shouldn't be about money. Why are we talking about money? And so I think that there's a disconnect sometimes, and I think that's starting to shift. And then we also have started to hear much, much more about local and global, and not being about somewhere out there, but being about local as well, and long-term partnerships. So I think global health is starting to have the language to address a lot of the inequities that we saw in Global Health 1.0, but I think that we run the risk of, like we hear the term greenwashing with corporations, like they know what to say to do to be seen as environmental. And I think that our institutions oftentimes know what the North Star is, whether or not we get there. And so I think for us in this room is to start holding our institutions accountable that some of these stated values actually play out in real time. And so I think going to Global Health 3.0 is really starting to push for justice, going beyond language, and then having institutions that mirror diversity and justice. And I mentioned this already a little bit, but when we were in 2013 and 14, when Ebola broke out in Liberia, we had a fellow who was going to Liberia as part of her Global Health Fellowship. And so obviously it was, it carries its risks. But I think one of the things that frustrated a lot of us was that a lot of institutions that were working in Liberia decided to pull back and not send their fellows or not send their faculty. And, it wasn't necessarily just a disaster response. It was people that had been working in these communities for a long time that decided to now pull back. And I think that that's where, we have to move. If you're a fireman and there's a fire, that's your job, right? You have to go into the burning house. And the same thing, if global health is going to move from being entertainment, where it's, a great emotional experience for us, to justice, then there has to be some level of solidarity and transfer of power that happens. So, and institutions, to their credit, I think some institutions, as they start hearing from people as, enough health professionals, I think a lot of us have probably more power than we think in a lot of these institutions. We wrote this article in the Huffington Post that got picked up by the New England Journal of Medicine in some form, saying that universities need to push towards committing a lot of their expertise, health workforce that really want to do good and want to support a place that is really suffering at a time when they need it most. And so there was some yielding, and there was, a larger conversation. So we need to think like 10, 15, 20 years from now, or, the next outbreak, or a lot of places it's a chronic emergency. Do we have kind of the level of commitment and matching up our institutions to their stated values? This is obviously another controversial thing that's been in the news. A colleague of mine who's at UCSF, Rupa Maria, Native Americans in North Dakota invited her to support a clinic there that would be an integrative clinic. It was a bunch of Native Americans that said we need some support in building up some health services for both the activists at Standing Rock as well as the Native Americans. And I think she's had a real tough time with our university, like trying to get buy-in from the leadership. And so I think that, oftentimes, and this is not, a straightforward case, but I think oftentimes, movements really push our institutions to change. And I know that, the White Coat for Black Lives movement amongst medical students and the Black Lives Matter movement has really pushed diversity in our institutions. So there is this power of movements that I think can really push our institutions to move towards a Global Health 3.0. And so when we talk about Global Health 3.0, I think it's the language, moving from the language to the structures of how do we construct global health programs that move beyond language to having structures that replicate the worlds that we want to live in, right? And that means equity across boards. So, we have a board at HEAL, and we try to have Navajo Nation elders on the board. We try to have, Mexican health professionals, people that we're serving, the communities that we're serving, and, as well as other stakeholders. And so can we have boards that look like the communities that we're trying to serve? And then our budgets, I think there's always this comment of, if you show me your budget and I'll show you your values, right? And so I think in global health, how do we, when we look at budgets of the programs that we really admire, where are they spending their money? How are they using it towards reciprocity? How are they using it towards shifting power towards justice? And then programs and partnerships. And so, that really longitudinal, those deep relationships amongst organizations. And so I think it's harder to do than the language, because we're building these projects on such deep inequity. And so, I think for me, as I think about Global Health 3.0, it's looking at history, and I think there's a ton of medical professionals that we can lean on and look towards as to those that came before us that were really incredibly courageous. There's a woman named Dr. Wendy Orr during the South African apartheid that saw a number of prisoners. She was just out of her training, and she saw a number of prisoners that had all types of abuse on their body from the South African police. And her job was to just take care of the wounds or the broken bones, and it was not to ask questions. And she actually ended up asking questions and taking it to the South African Supreme Court. And she got a lot of flack for it, but there is this history. This is the Freedom Summer of 1963, and there was a medical committee for human rights that was part of that 1963 Civil Rights Freedom Summer that committed to that. In South Africa, the Divest movement, and now we're seeing, these die-ins. That picture on the top right is a die-in for a more diverse health workforce, as well as trying to get rid of racial bias in our, or accepting the level of outcomes for are brown and black American citizens. So I think that there's this real potential for movements and looking towards, looking behind us as to a lot of the people that have come before us to push our institutions towards more justice. And so I think the Global Health 3.0 movement, just to recap, I think the 1.0 was very much had its colonial roots. It's about emotional experiments. The Global Health 2.0 is really starting to treat the burden of disease, piggybacks on the HIV movement. And I think the Global Health 3.0 movement, at least, from HEAL's perspective, we're trying to get that there. And it's really transferring power to people and communities that are suffering most and building this solidarity, justice, and equity framework to structurally shift our institutions. Because I think that, frankly, a lot of your interest in global health has pushed so many global health programs from rising up, right? If medical students and residents weren't, and nursing students and public health students weren't committed and interested in global health, I think a lot of these institutions wouldn't have programs. They use those programs to attract a lot of students, and now it's your job to try to go one step further and really shape those institutions to reflect and structurally reflect the values that we want in global health. And so I'll end with this last story. So, there's a man named Miles Horton. So Paulo Freire was a famous Brazilian educator, and Miles Horton was he was in the 1930s and 1940s. He taught adult literacy to people that worked in mines, and he literally just had this school where he started to educate all the communities that worked around mines. And that school became more and more committed to, I think, transformational practices of trying to see the people that were very poor take control of their lives. And so Rosa Parks, Miles Horton School, which is called the Highlander School, became a school that Rosa Parks and Martin Luther King gained a lot of their, they came of age in that school. And if you asked Rosa Parks at the end of her life, she would give credit to this school, but she never said that this school gave her the organizing skills or the technical skills to be efficacious. She said that this school shaped the way she was in the world. It changed her way of being. And so I think that in global health, the opportunity that we have is to shift our way of being by walking the road and really making the road by walking it. And, I think that the question for all of us in this room is, what is that global health solidarity movement going to look like? Because I don't think it can look like, the 1.0 or the 2.0. And I think we can shape our institutions to make it look so much more like the world that we want to live in and embody. So, thank you.
Okay, now we're just going to take a short 5-10 minute break, and we're going to get back in here at 6:05 so we can get started with our documentary screening. And so we'll get that set up for you guys, and stick around for more Global Health Conference fun.